Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy. I'm Marv Goldfried and my colleague out in California.
Hi, Alan Francis. Hey, Marvin. How are you?
Okay. It's a beautiful day in New York, 80s. I don't know, you look like you're freezing.
It never gets above 65 or 66 in
Really?
Yeah, right.
It's good for fishing, though. Perfect temperature for fishing. You should really try that. Anyway, we're not going to talk about fishing. We're going to talk about the third wave in cognitive behavior therapy. I'm curious about your interest in this and interested in hearing what you have to say about it from your vantage point.
Maybe you should explain what the third wave is.
Yeah, that's a good point. Back in the 60s, a group of us fostered this approach to therapy based on learning research. And basically, it was even more broadly, let's develop a form of therapy that has an empirical basis in research. And the research at the time was classical and operant conditioning. So behavior therapy came into being. And then with clinical practice, we found out that our patients had this very annoying tendency to think. And there wasn't very much research on that, so we needed to introduce cognition into behavior therapy. And that was the second wave. And then in more recent years, there are some CBT therapists who have proclaimed that there is a new wave, a third wave. And this third wave is different from the others, and it involves several new factors that need to be emphasized, namely acceptance on the part of patients that they may not be able to change certain things, mindfulness, and various other people come in and say, my therapy is part of the third wave.
I think I counted it once, and there are about 50 different named therapies now, most of them part of the third wave of cognitive.
Really?
Yeah, the 50 different, therapies that now have initials trying to distinguish themselves from other therapies, usually related to a charismatic founder.
Right. And this is within CBT for the most part.
Most of them are CBT. Yeah.
Yeah. So what's your take on it?
Well, I've fought against it in an unsuccessful way, particularly with Marsha Linehan with dialectic behavior therapy. I edited her books, and actually I got her to call the book Cognitive Behavior Therapy of Borderline Personality Disorder rather than dialectic behavior therapy. I was arguing with her that it was important not to constantly be fragmenting psychotherapies, constantly inventing new ones, but rather to see a unification of the therapies rather than their fragmentation. I convinced her enough to make the title of the book Cognitive Behavior Therapy, but really she kept it very separate in the way she did the training program. And I think most people would see dialectic behavior therapy as a separate form rather than within the rubric of cognitive behavior therapy. I once had a discussion with Steve Hayes along the same lines, that rather than seeing commitment and acceptance as something radically new and different, it was part of all good therapies to have commitment and acceptance. And it would be better to emphasize this as a technique of cognitive behavior therapy rather than as a brand new therapy.
Yes, well, we're both very much on the same page with that conclusion, and we can talk about some of the reasons why some people in the field took your advice and other people did. Did Marcia take your advice?
Enough to title the book Cognitive Behavior Therapy, but not really in the sense that the training program and the way it's labeled around the world as dialectic behavior therapy. She was very attached to the word dialectic, I think, because it had great meaning to her in terms of the Zen Buddhism and the idea that she was integrating the people's tendency to feel very split apart, and that bringing together the synthesis of dialectical parts of the individual and the dialectic of you really are doing the best you can now, but it's also important you change. That particular kind of paradox she was very attached to. But I think we have to recognize that most therapies are developed, all therapies that are new are developed by charismatic leaders. And whoever develops the therapy then becomes very attached to it being done just the way they want it done, labeled just the way they want it labeled. It's very hard for people to see themselves as troops in the larger unified form of psychotherapy.
Yeah.
Each of the people who develops a therapy tends to see themselves as a kind of hero bringing something new to the world, a kind of messiah bringing something new into the world.
Yeah, it says more about their needs, from my point of view, than the needs of the field or the needs of the patient.
I think it also says something about how the parallel between psychotherapy and religions, that religions all tend to be schismatic. There's never been a religion that remains in its original form, that there's always break-off groups, and then break-off groups off the break-off groups, then break-off groups off the break-off groups of the break-off groups. And I think that psychotherapy has the same inherent tendency to be split into parts as individuals feel that they have something to offer that's radically new than what came before.
Well, let me pick up on the point of the dialectical thing. I know it's a little bit tangential, but I'll be curious as to whether you agree with what I have to say, because I see the dialectical thing as somewhat different. It's not so much split off characteristics of the patient, but rather the attempt to apply, Marcia's attempt to apply CBT to patients who were very sensitive to criticism, so ultra sensitive that if she said, well, if you have a problem, here's a solution, or I hear you have a problem, so here's the solution, and they didn't want to hear that they had a problem because they grew up hearing that, you're much too emotional, you take things too seriously, what's wrong with you? So she recognized that she could not use what she learned about CBT to these borderline patients unless they asked for it. And I think that's where the acceptance comes in, and they are accepted as kind of like an unconditional positive regard in a person-centered way, and then the person feels safe to say, okay, well, you get me, you understand me, you accept me, can you help me to change? And that's what I see as the essence of DBT.
Well, Marcia had spent 2 years herself on a hospital ward when she was a teenager. A lot of that in solitary confinement, and because she was cutting and banging her head against the wall.
Right.
She felt terribly misunderstood
and total lack of understanding. So she was able to resonate with that.
She felt that what she needed was someone to be nice to her.
Yes.
Accepting of her.
And so is that a new form of CBT? I mean, I don't think she saw this as a third wave, but I'm not sure. I think other people may be seeing it this way.
Marcia was, eventually went ahead with labeling it a cognitive behavior therapy of borderline. So that I think she had mixed feelings about it. And again, everything also gets tied into external factors like, will I get a grant? Would she be more likely to get a grant if it's labeled dialectic versus cognitive?
Yeah.
The practical realities. Can I start a training program if I just call it cognitive versus if I call it dialectic? Which will sell more books? Will it sell more books if it's labeled?
And get more funding because it's new.
Yeah.
Yeah.
So I think that there are external factors that create this alphabet soup of 50 different brands of therapy, many of them third wave CBT. But I think also the founder effect is very important.
Yes. Yeah. And I think Hayes pushed this much more than Marcia. I think she maybe went along with the ride silently and not protesting too much. And maybe also her followers, just the term followers. What are her followers? So that speaks to the fact that I'm following the leader of this orientation and the identity that comes with it. And I think that, that makes it very, very hard for the field of therapy to move ahead and get some kind of consensus. But maybe that's another discussion.
And I think there's both good and bad in the idea of a third wave and having 50 different kinds of therapy. The good part is that it gets people excited. Marcia created a network of tens of thousands of clinicians all over the world. Probably she would have not been able to do that if she just called it another technique of cognitive behavior therapy. By making it different, a new and different form of therapy with a different name, she was able to capture the attention and interest of tens of thousands of followers.
Yeah.
The bad part is that people have a tendency to feel like I am a loyal servant of this school, and therefore I have to defend it against other schools. It reduces the range of individual therapists if they feel they're providing one kind of therapy when it's really just a technique. And most therapists should be skilled in all the techniques that are the wide range of problems we see.
Yeah, and those are certainly problems, and there are even more serious problems. Somebody once said that the problem with the third wave is that there's the danger that it washes away everything that occurred before that, which is a very interesting use of the metaphor. And I think that is happening. People now in CBT, they're finding it very important to learn acceptance and commitment therapy, Hayes' ACT, ACT, Marcia Linehan's approach, behavioral activation, all these new things. At times, I believe it's at the expense of everything that has happened before that in the first and second waves, stuff that really is important and really works. So I'm not quite sure that I know what CBT is anymore. And then even worse, learning it from a manual, which of course is your most unfavorite issue.
How do the training programs factor into this?
Well, we love what's new. When I was teaching and supervising, I never included ACT because I felt that in a sense, the only thing that was new, and that wasn't even new, was the name, acceptance and commitment. Basically, it was old wine in new bottles. And even worse, the old wine didn't taste as good when it was transferred to new bottles. Hard to follow some of the concepts in ACT. And the only way I really understand it is it's a takeoff on Werner Erhardt's EST therapy, Erhardt seminars training. This is from the 70s, where he took a little bit of Buddhism, he took various types of contributions and then presented them to large groups. And there were two themes in his training. One was you need to accept what you can change rather than bemoan it. And you also have to live up to your commitments. So one was a cognitive aspect of acceptance, and the other was behavioral. Live up to your commitments. So I see this as the roots of the third wave. And this is not my understanding of what behavior therapy or CBT should be. It should be based on basic research findings involving how people learn, how people think, how people feel, how people interact with others. This came from somewhere else.
Well, it's actually, though, there's a parallel in a slightly different direction. Like interpersonal therapy, its own popular fad in the last 30 years. And the history of that's interesting. It was developed by Jerry Klerman, one of my mentors, and Myrna Weissman, his wife, one of my friends. And they were not clinicians. Neither of them was a clinician. But they wanted to have an approach that could be studied in psychotherapy comparison trials. In those days, it was usually interpersonal versus cognitive therapy versus medication for a variety of problems. So they developed what's really just plain old therapy. There's nothing in interpersonal therapy that wouldn't have been completely just what came before, that every therapist would naturally be doing. They created a manual with almost no clinical experience. Neither of them had any clinical experience. But they created a manual of things that were meant to be interpersonal in nature, dealing with the disappointments and difficulties and transitions around the interpersonal life of an individual. And that became a new therapy, as if it was something different from what everyone had always been doing before.
Yeah.
So research, in a way, you're defending research as one of the reasons why we should be loyal to the second wave. But research also created a schismatic tendency.
Yeah.
People needed to label their therapy in order to get and manualize it in order to get a research grant.
No, I know that it's the research grant. And you needed a research grant in order to get a position at a university, because the researchers brought with them not only the money to fund their research, but something like roughly 50% or sometimes more on top of that as overhead that goes to the university. So, I mean, these are the economic and political issues that drive the field, which is unfortunate, but it's hard to get around that. Let me tell you another one of my gripes about the new. It's new implies improved. Old is bad. I once asked a group of graduate students, take the next minute and write down all the thoughts you had associated with the word new. And they did that. And I said, now take the next minute to write down all the thoughts that you have associated with old. And they wrote that down. And then I said, now classify them into positive and negative within each category. Virtually all of the associations with new were positive. About half were positive for old. Old was tired, worn out, passé.
Guys like you and me.
Yes, guys like you and me. Right. And people like what's new.
Yeah.
So the new approach to CBT is acceptance, it's mindfulness, it's ACT, it's all these things. What happens then is that people who are going to do a literature search to find out what's been done in an area no longer look at the old terms. They look at the new terms. So they don't know from unassertiveness. And they don't look that up. So there's decades of clinical observations, clinical contributions, and research that become lost to the field once you put new labels on things.
Yeah, actually, Marvin, that occurs to me. I would argue that the first wave of cognitive therapy was the Stoic philosophers 2,000 years ago.
Yeah.
And if someone really wants to get the gist of cognitive therapy, the easiest and maybe most vivid way of doing it is to Google the quotations of Epictetus, a Greek slave who rose to be an advisor to emperors. And everything in cognitive therapy, every idea in cognitive therapy very articulately expressed by him. And to their credit, both Tim Beck and Albert Ellis credited the Stoic philosophers with providing the bedrock of what they put into cognitive therapy. The Arabs reinvented. The Arabs read the ancient literatures, and in the years between 800 and about 1200, they also reinvented cognitive therapy. So when we say there's nothing new under the sun, we're not just talking about the first wave and second wave, 50 and 30 years ago, 40 years ago. We're talking about 2,000 years ago. That nature hasn't changed much, and ways of understanding it haven't been developed just in the last 50 or 100 years.
Yeah. But I think beginning therapists are far less interested in that than they are in applying the new approaches in CBT. And what happens is that it sometimes is applied indiscriminately, like mindfulness. Not mindfulness, let's take acceptance. John Teasdale, brilliant British psychologist, recognized that people with depression have repeated episodes of depression. And he reasoned that maybe one of the factors that contribute to this is that when they have a recurrent depressive episode or start to feel sad, they get depressed about getting depressed. And he reasoned that they need to just accept the fact that they're going to be depressed every once in a while. So he built in an acceptance into a CBT orientation. And then all of a sudden, acceptance became very, very popular for everything. It's designed for one particular purpose, but then it becomes a CBT technique. Well, let's try it on this and let's try it on that. And I don't think it's new. I think acceptance is the realization that not everybody can change. And the part of CBT therapists, when we first got started, we believed we could do everything. And with clinical maturity, we recognize there are certain people that are just so constitutionally disposed to be a certain way, or their early experiences was so severe and chronic that it's going to be very hard to get rid of that. And I think that's a recognition that there's limitations, but that's not justification for a new wave.
So, Marvin, let's pull out your crystal ball. What do you think the fourth wave will be like?
You're asking for a fantasy. Well, I have a crystal ball, actually. It's a little crystal ball.
Just happen to have one handy.
But I look in it, all I see is my face and your face. So I don't think this is going to really work. I don't know. It's very, very hard to predict because so many different factors, economic factors, political factors play a role. The shift of the NIMH to the medical emphasis couldn't have easily been predicted, but it happened. And according to Barry Wolf, who you know, who was a staff member at the NIMH for over 20 years, his hypothesis was that the drugs that were being developed by Big Pharma were not working as well as the old ones, which were generic. So they needed to get biomarkers. So they moved, well, even before that, they needed to develop new drugs, and they thought they could do it with clinical trials and diagnostic disorders. That didn't seem to work, so they went to looking for biomarkers, RDoc, and that didn't work either. So who could have predicted that the NIMH, which was so supportive of psychotherapy and psychotherapy research, would essentially turn its back on that? So I'm not going to predict.
You're not going to predict the future?
No.
Future's hard to predict, especially because it hasn't happened yet. My Yogi Berrism. I don't know. I think that there's been an interesting evolution in the last couple of years with the combination of COVID pushing for the necessity of teletherapy,
Yeah.
and also with the increase in reporting of mental health symptoms, so that it's now much more normalized to have mental health symptoms than it might have been 15 years ago.
Yeah. Right.
An enormous part of the population is experiencing sadness, depression, grief, anxiety. It's very normalized amongst teenagers now, to realization that many of them need psychotherapeutic help. My guess is that psychotherapy will become more and more popular with time, and probably geared more and more to the problems of everyday life,
Mhm.
and less medicalized towards, and I'm not sure that there's both good and bad to this, but I think that the psychotherapist probably will be trained more and more to do teletherapy and to do it with people
Yes.
who have more problems of everyday life than defined disorders.
Yeah. Well, this is really not a it's not a prediction. It's more of a fantasy or for a wish. I think one of the many major difficulties of having us come up with some consensus in the field of psychotherapy is that the different schools of thought provide a useful identity for the therapist. I'm a Freudian, I'm a Rogerian, I'm a CBT, and I'm a this and I'm a that. And within the field of medicine, you don't have that. The identity of physicians has to do with their area of specialty. So I'm a trauma therapist. I'm a couples therapist. I'm a therapist that deals with developmental disorders. These things do exist. And it's just a question of whether this will continue so that therapists use that as their identity rather than a school of thought.
It's really interesting. Another way of putting this is that the schisms that we discussed before are part of tribalism, and that people need to feel like they're part of a tribe.
Yes.
And that the alphabet soup of therapies is providing sub-tribes for people who are psychotherapists in general, but gives them a particular home and an identity.
Yeah. And I think that's important.
And the trouble with that is, it's a good thing in one sense, but the trouble with that is that if you establish yourself around one identity as a therapist, you're limiting yourself to the wide world of technique.
Yeah.
That is especially necessary because the patients don't come in schools.
Right.
They don't come with discrete problems that one school is particularly good at handling. And people who are specialists in therapy tend to be very limited in the kinds of patients they can treat.
On that note, and looking at the clock, I think our time
Okay, Marvin.
is up. I would look forward to next week and whatever we decide to talk about then.
You're always a highlight of the week, Marvin.
You're the highlight of my week too.
Hey, take care.
You too. Stay safe.
Bye-bye.
Bye-bye.